Okay, it's exactly 2 o'clock, and I think we'll get started. I want to welcome everybody on this call to the Best of SWOG at ASCO. We are super excited to have this opportunity to hear about some of the fabulous presentations from all the hard work that everybody does for the trials at SWOG. It takes a village, so while one person will be presenting, they really present on behalf of everybody that participates in all of the different aspects of what it takes to get one of these studies from inception to presentation. And we have a great list of speakers. Dr. Blanky couldn't be with us today because he is at the White House talking about clinical trials. So also very exciting activity in terms of our global impact and involvement. And so with that, I think we'll get started with the first presentation given by Dr. Meghna Trivedi, talking about the results from S1714 risk prediction model for taxane-induced peripheral neuropathy in patients with early stage cancer. So with that, I will hand the microphone over to Dr. Trivedi to give us, I think it's an 8-minute presentation, and then there'll be 4 minutes for questions. So anybody who has any questions, type them in the chat and we can go over them after. Take it away.
Great. Thanks so much, Dr. Hershman. So thank you for the invitation to present at SWOG's Best of ASCO. And on behalf of my co-authors, I'm excited to present our work from S1714 and the risk prediction model for taxane-induced peripheral neuropathy. Next slide. So just as background, taxanes like paclitaxel and docetaxel are frequently used in the treatment of cancer. TIPN has been reported in up to 70% of patients receiving taxanes and can present with sensory, motor, or autonomic symptoms. The majority of the data on the rates of TIPN come from therapeutic clinical trials, which often have strict eligibility criteria that can exclude some of those individuals with comorbid conditions. Unfortunately, there are limited options for prevention and treatment of TIPN, and the mainstay of management of TIPN is chemotherapy dose modification. Not only can TIPN symptoms impact the quality of life, but it can also limit the ability to administer the standard doses of chemotherapy, which may ultimately affect long-term outcomes like survival. So identifying predictors of TIPN can aid in treatment decision-making and counseling for patients. Next slide. S1714 was designed as a prospective observational cohort study of individuals with stage 1 through 3 primary lung, breast, and ovarian cancer who are undergoing treatment with a taxane-based chemotherapy regimen. Over a 3-year period of the study, we assessed neuropathy using multiple different measures, and we also collected biospecimen samples as well as treatment modification data. Between March 2019 and November 2021, the trial enrolled 1,336 patients at 105 sites in the NCORP. In this analysis, we'll focus on the data collected between registration and week 24. We can advance the slide, and then next slide. The primary objective of S1714 is to develop and validate a clinical risk prediction model for the development of peripheral neuropathy by week 24 in patients receiving taxane-based chemotherapy regimens using baseline clinical factors. Next slide. For the primary endpoint measure of development of neuropathy, we chose the patient-reported EORTC CIPN-20. While there are many ways to to assess CIPN, including patient as well as physician measures, several studies suggest that physician-assessed measures may underestimate CIPN symptoms in patients. The CIPN-20 consists of 3 subscales, the sensory subscale, motor, as well as autonomic, and each subscale is reported on a scale of 0 to 100, with a higher score indicating worse symptoms. In this study, we used the we used an increase in the CIPN-20 sensory subscale score of 8 points or more at any time point through week 24 to define the development of TIPN. This definition was based on multiple studies indicating that patients with chemotherapy-induced peripheral neuropathy experience a 7 to 10 point increase in the CIPN-20 sensory subscale score. Next slide. We used a two-step training and test approach to develop a TIPN risk prediction model. In step one, we used a training set of a 60% random sample from the 1,278 evaluable patients. Best subset selection identified a best model from among a set of demographic, baseline comorbid, oncologic, and treatment factors. Model building was based on a logistic regression using a k-fold cross-validation. And a risk model was developed by summing the adverse risk factors and creating high versus low groups by splitting at the median. In step two, the proposed risk model developed in step one was tested in the remaining set of 40% of evaluable patients. And the aim was to detect a 15% absolute difference in TIPN between the high versus low risk groups. Next slide. In this slide, we showed the baseline demographics, baseline comorbid, oncologic treatment factors that were considered for inclusion in the model. Next slide. So here, there are a bunch of animations, so they may not go through the right way with this method, but we'll basically highlight all of the baseline characteristics of the total cohort. In general, the factors were well balanced between the training and test sets due to random selection. In S1714, we included predominantly women. There were 18% of the individuals self-identified as non-white race and 11% self-identified as Hispanic or Latino. Next slide. And next. Okay. About 10% had a history of fall within 6 months of registration, and the two most common baseline conditions were diabetes and thyroid disease. The majority of patients were never smokers, and the mean baseline, there was minimal baseline neuropathy in this cohort by the CIPN 20 sensory scale. 75% of patients had a performance status of 0. Next slide. The majority of patients in this cohort had a diagnosis of breast cancer, and 60% had stage 2 or 3 cancer. Next slide. And then finally, looking at the treatment factors, so taxane-based regimens that were eligible for enrollment in S1714 were pre-specified and included either paclitaxel or docetaxel. The majority, about 60%, received paclitaxel. The majority received either weekly or tri-weekly dosing. Almost all patients were planned to receive full dose of taxane, and 75% were planned to receive less than or equal to 12 weeks of taxane treatment. The use of concurrent platinum agent was allowed per protocol and was used in about 1/3 of the patients. Next slide. So here are our results from the training set. So by week 24, the rate of TIPN in evaluable patients was 62%. The training set was composed of 768 patients, and using this data set, the risk model included the following 5 risk factors. The receipt of paclitaxel, a stage 2 or 3 disease, having a planned duration of taxane treatment greater than 12 weeks, having one or more of the following diagnoses at baseline: diabetes, autoimmune disease, or moderate kidney disease, and finally, self-identification as Black, Native American, Pacific Islander, or multiple race, or Hispanic ethnicity. Low risk was defined as having 0 to 1 risk factors, and 35% of patients in this training set met this criteria, of which 48.7% experienced TIPN. High risk was defined as having 2 or more risk factors, and 65% of patients in the training set met this criteria, of which 70.9% experienced TIPN. Next slide. In step 2, we applied the model to the test set of the remaining 510 patients. 1/3 of patients in the test set met low risk criteria, and from this group, 50.9% experienced TIPN, and 2/3 of patients in the test set met high risk criteria, and from this group, 68.3% experienced TIPN. The absolute difference between the percentage of TIPN between the high risk and low risk group was 17.4%, which exceeded the target difference of 15%. Next slide. When we stratify the entire cohort of evaluable patients by number of risk factors, we see that the risk of TIPN increases substantially as quartile level risk increased, from 39.5% in those with no risk factors to 76.3% in those with 3 to 5 risk factors, a nearly 40% difference between those at the highest and lowest risk. Next slide. This forest plot shows the odds of TIPN based on the different model types using the entire evaluable cohort. And I just want to highlight, when using the 4-level or quartile model, there's a nearly 5-fold increased risk of TIPN in those in the highest quartile with 3 to 5 risk factors versus those in the lowest quartile with 0 risk factors. Last slide, or next slide. So in conclusion, in this cohort of patients in S1714, the rate of TIPN by 24 weeks was 62%. We found that a limited set of demographic, baseline comorbid, oncologic, and treatment factors can be used to predict TIPN risk, and our model demonstrates a nearly 5-fold increased risk of TIPN in those with 3 to 5 risk factors versus those with 0 risk factors. By improving the ability to predict TIPN risk, we may be able to guide patient care and decision-making. And the risk prediction may help inform shared decision-making between patients and physicians on chemotherapy choices, as well as prioritizing high-risk patients for enrollment to clinical trials of CIPN prevention strategies. Future work to refine the risk prediction using physiologic and genetic biomarkers is ongoing. And next slide. The acknowledgements. So I'd like to acknowledge our funding support from the NCI and the Hope Foundation. And thanks, of course, to all of the institutions and patients who participated in this study.
That was terrific. Thank you so much for that presentation. If anybody has any questions for Dr. Trivedi, just type them in the chat. In the meantime, we did hear about another similar study that was done in ECOG Akron, specifically focused on Black patients. This study looked at higher risk amongst African American patients. How do you think we can use these studies together to better understand how to inform patients about their decision making?
Yeah, I think that's a great question. I think, knowing that certain groups are at an increased risk for developing neuropathy and being able to predict that risk can help us not only inform patients about what their treatment options are, but also to help them make chemotherapy decision-making, help improve their ability to decide on their final chemotherapy regimen. I think our hope and goal, as both of these trials were being run, was to try and harmonize the collection of data so that we could even ultimately try and combine these cohorts in order to better refine risk prediction amongst, those at highest risk, whether Black or non-Black, and trying to use this data to help inform treatment decision-making in the future.
Terrific. Are there any other questions from our audience? I think one of the questions here's one. You mentioned that patients at high risk could possibly be treated to prevent the neuropathy. What options are currently FDA approved or under study?
So great question. So for prevention, the options as far as FDA approval are limited, but through SWOG S1007 we're actually looking at cryocompression as a way to prevent doing the prevention of taxane-induced peripheral neuropathy. So a plug for that study to try and investigate and understand what we can do to better improve prevention techniques for neuropathy. But currently there are no standard or FDA approved methods to prevent neuropathy. It's usually just dose modification of chemotherapy.
Great, thank you. And I thank you again for your presentation. And I think we'll go on to the next presenter, who is Dr. Kevin Kalinsky, who we all know from Emory. Will be talking about anti-Müllerian hormone levels to refine identification of premenopausal patients with hormone receptor positive, HER2 negative, node positive breast cancer who are more likely to identify benefit from adjuvant chemotherapy. These are results from SWOG S1007 for the responder trial. So take it away, Dr. Kalinsky.
Thank you, Dr. Hershman. And I think you really touched on the sentiment that I wanted to bring up as well, is that this is very much a group effort. And what I'm demonstrating to you here is team science, where this was really a collaboration. I'm just happen to be presenting these data. Next slide. As a reminder, the responder trial was a global study of 5,000 participants with hormone receptor positive, HER2 negative breast cancer with 1 to 3 nodes involved. We utilized the 21 gene recurrence score ASCO. If the score was 0 to 25, participants were randomly assigned to chemotherapy followed by endocrine therapy versus endocrine therapy alone. Next slide. What we previously reported is that patients who were post-menopausal, which is what I'm showing on the right, which was 2/3 of the patients, those patients did not have benefit from chemotherapy. Patients on the left who were premenopausal, there was a 5-year invasive disease-free survival absolute benefit with the addition of chemotherapy. And you can see at the bottom of the slide how we defined menopausal status, where patient was defined as premenopausal if the last menstrual period was less than 6 months, postmenopausal if the last menstrual period was greater than 12 months, or if somebody had undergone a bilateral subpenial oophorectomy. However, if somebody was between those 6 to 12 months in terms of their last menstrual period and aged less than 50, then they were classified as premenopausal. So you can see the way that we defined it was somewhat crude. Next slide. As Dr. Trivedi mentioned, this slide also actually has some animation as well, so just bear with me. As some background, AMH, or anti-Müllerian hormone, reflects fewer growing follicles, as shown on the pictorial to the right. Compared to other hormone levels like estradiol and FSH, AMH is thought to be more reliable and stable during a menstrual period. Next. As shown in this illustration, AMH is demonstrated in purple, decreases prior to the final menstrual period before what we see with FSH elevation. FSH elevation is shown in green. Next. Similar to AMH, inhibin B also declines before menopausal status and is also thought to reflect the follicular number and function. Next slide. So our objective of this exploratory analysis was to determine the chemotherapy benefit if a woman was less than 55 years of age using serum markers of ovarian function or reserve. And the reason we use 55 as a cutoff is the majority of women have undergone menopause by this age. Serum hormone levels in postmenopausal women is defined as having a low estradiol, progesterone, AMH, inhibin B, or high FSH and high FSH and LH. Next slide. Next. So of women who are aged less than 55, 1,000 women had been defined in responder as premenopausal. And those are the patients that I'm going to be evaluating. Like, these are the patients who have pre-treatment serum available and analyzable of those women who are less than 55. So I'm only going to be focusing on those women who had originally been classified as premenopausal. The other thing I would just mention is that, this was a global study. It includes all patients that are less than 55, except for the French patients. Those patients are being utilized as a validation cohort. Next. So when we look at estradiol, progesterone, FSH, and LH, it's less than 20% of women who were less than 55 who'd been classified as premenopausal had these hormone levels that were in the postmenopausal range. And we used the cutoff as shown on the right on the table based upon standard cutoffs used in other studies. Next. When we look at AMH, you can see that low AMH, which is defined as less than 10 picograms per ml per traditional ELISA assay, that rate of, again, these premenopausal women that were less than 55 had a serum AMH that was in the postmenopausal range. So a low AMH, again, less than 10, associates with being at a patient's final menstrual period or later. Medium, which is between 10 to 100, is less than 10 years from final menstrual period, and high, greater than or equal to 100, is greater than 5 years from the final menstrual period. Next. The other thing, just to highlight, and it's shown in the illustration, but just to categorize this, those women who are aged less than 45, less than 3% had a low AMH. If it was a participant was age 45 to 49, it was around 15%. And if a participant was age 50 to 54, it was a little bit greater than 50%. Next slide. So when we performed a Cox model, when including in that model variables like stage, number of nodes, and grade, age. When we look at premenopausal women that was less than 55 years of age, whether it was categorical continuous, was not predictive of chemotherapy benefit. Next. AMH, however, was. And again, we were adjusting for treatment arm recurrence score variable, and we're testing the interaction of that variable in treatment for significance. So AMH in this population was predictive of chemotherapy benefit. Next slide. Inhibin B, there was a trend towards significance, though AMH and Inhibin B were strongly correlated. And AMH was a better predictor of chemotherapy benefit. So for the remainder of the slides, I'm going to be focusing on AMH. Next. So for premenopausal women less than 55 years of age who have a low AMH, again, this is 21% of the population as shown on the left, no invasive disease-free survival benefit for these patients. Patients who had medium or high AMH, that's 7.8% improvement in 5-year invasive disease-free survival with chemotherapy with a hazard ratio of 0.4. I can't see if that's 6 or 8, but less than 0.5. And there was a significant interaction of 0.019 when adjusting for recurrence score. Next. The same trend was seen with distant relapse-free survival. Low AMH, no improvement of distant relapse-free survival in these women who'd been classified as premenopausal that were less than 55. Those with medium or high AMH, there was around a 4.5% improvement in 5-year DRFS with chemo. Next slide. So in conclusion, in responder, women who've been classified as premenopausal that were less than 55 with 1 to 3 nodes involved who had a recurrence score of 25 or less, 21% of these patients had a low AMH as determined by a traditional ELISA assay, and these patients did not benefit from the addition of chemotherapy to endocrine therapy. As I mentioned, around 50% of women aged 50 to 54 had a low pretreatment serum AMH. Those that were less than 45, that rate is low at 3%. I mentioned how AMH was a better indicator of adjuvant chemotherapy benefit than reported menopausal stage, age, or other serum hormone levels. I mentioned that there are ongoing validation efforts that we will include in the paper from our French colleagues. And in conclusion, low serum AMH could classify who can safely forego adjuvant chemo in women whose menopausal status is unclear. I look forward to your questions. And again, this was a team effort within SWOG. Thank you.
Thank you so much for that fantastic presentation. It's super exciting to see these results. How do you think clinicians should use this in practice? Should they be getting AMH on everybody since it's a better predictor? Who are the people that you would suggest that we get AMH on?
So I think right now it is something to consider in patients who have an unclear menopausal status. So I think it's for those patients who might have had a hysterectomy who still have their ovaries. Another option is for those patients, again, who are age 50 to 54, where their periods are maybe a little bit more irregular. We saw that these patients had about a 50% chance of having a low AMH. Less than 45, very few patients had a low AMH. You know, the other thing just to keep in mind is that we used the traditional ELISA assay. I didn't mention this was at the Biomarker Discovery Lab at University of Kansas Medical Center by Andy Godwin and Hershman and colleagues. And so if one sends it, it is important to know what assay one has at one's institution. Not all assays are the same. Some have different lower limits of detection. In the presentation, we reported some concordance that we did with an additional assay, but there are other assays that were actually clinically available assays that we're now doing correlation studies with the traditional ELISA assay.
So the question in the chat really is, you know, what you just spoke about. So can you just order an AMH level in clinical practice now? And how does that compare to what you did?
You can. I will also say, like, for instance, here we utilize the Roche-Cobas assay. The lower limit of detection for that assay is 0.3 picograms per ml. So if one sends it, then one has to keep that in mind. The other thing that I will say, and I do have Andy's permission to state this, is that they, meaning the University of Kansas, is willing to do clinical assays on patients. It's not an CLIA approved lab. But if anybody on this call would like for me to connect them with that lab, they really are willing to do that for patients while these correlation studies are ongoing.
Fabulous. Well, with that, I think we'll move on to the next presentation. Thank you so much for this and for all that you do for SWOG. On the same theme is another analysis from RxPONDER that will be presented by Lajos Pusztai, who I hope is on.
Yes.
Anyway. Okay, all right, good, thanks. And he'll be talking about the development and validation of RSClin N positive tool for hormone receptor positive, HER2 negative, node positive breast cancer. So Lajos, thank you for joining us, and we look forward to your presentation.
Thank you. It's really great to have this opportunity to share these results with you as well. So one of the common mistakes that we make is that we take the average result from a randomized trial and apply it to individual patients. So in RxPONDER, for example, the average result was a 5% improvement in recurrence-free survival or invasive disease-free survival in the premenopausal population, regardless of the recurrence score value, right? But the truth is that the actual risk of patients to recur with endocrine therapy alone and the absolute benefit that they get from chemotherapy on top of adjuvant chemotherapy, on top of the endocrine treatment, really varies. So the goal of this project was to really create a multivariate model that provides a personalized, individualized risk prediction for an individual in terms of absolute risk of recurrence at 5 years and an absolute improvement that they could expect with chemotherapy. I don't think I control the slides. So if you could move to the next slide. Yeah, so such a tool you may already be familiar with. It exists for the node negative, ER positive patients, and it's called RSClin, and it's available through the Exact Sciences website. And it uses information from the recurrence score value, the age of the patient, the grade, the size of the tumor, and makes a prediction about what's the risk of recurrence in 5 and 10 years with endocrine therapy alone, how much it improves or doesn't with adding chemotherapy to it. So we wanted to build the same tool for the node positive patients. That's why we call it RSClin N+. Next slide, please. So to build this model, we used pretty much all the patients from RxPONDER except 67 who had missing values for the recurrence score or grade. And we also included patients from SWOG 8814, from the tamoxifen and CAF-T or FAC chemotherapy plus tamoxifen arm that had recurrence score values. So this is the translational sub-study. So we did some statistical tests to make sure that it's possible to pool and it's statistically valid to pool the two studies, and ended up with about 5,000 patients combined from RxPONDER and the translational sub-study. 1/3 of them were premenopausal, about 2/3 postmenopausal, as you would expect. And we validated the model on a totally independent sort of real-world data set, the CLALIT Health Service Registry. That's an Israeli health service registry where patients have the same information that we collected on these clinical trials, plus the recurrence score, plus long-term outcome. And they also received various types of therapies, chemotherapy or endocrine therapy, based on the physician's discretion. So that was the validation cohort that we used. Next slide. So this is the distribution of the patient characteristics. You probably are familiar with this from the parent trials. So a fair number of these patients were 1 to 2 positive lymph nodes, and higher number of positive nodes were only present in the S8814. And of course, the recurrence score only ranges from 0 to 24 in the RxPONDER population, and it ranges from 0 to 100, or the full range for the 8814 patients. All the 8814 patients are postmenopausal. The RxPONDER includes both pre and postmenopausal patients. And the validation cohort actually had a fairly similar distribution of patient characteristics as our discovery cohort in terms of the number of positive nodes, grade, and tumor size. Next slide. And this is the actual mathematical model. So we predict 5-year invasive disease-free survival because that's the data that's available on RxPONDER and also on S8814. So the median follow-up in RxPONDER is around 5 years. So that's why we couldn't really make reliable predictions beyond. Can you go back, please? Yeah. So the variables that go into the premenopausal model is the recurrence score value, the tumor grade as low, intermediate, or high. So you would need to put that into the model. Tumor size is T1, T2, T3, patient age, and the chemotherapy use that it predicts the added benefit. So you note that number of nodes is not included because, interestingly, in this large study, the number of nodes in the premenopausal population didn't really matter. Your risk was the same if you had 1, 2, or 3 nodes. But keep in mind, this is all low recurrence score, less than 0.25. On the other hand, in the postmenopausal model, the same variables are going into the model, but also the number of nodes, because in the postmenopausal population, the number of nodes did matter. So it actually goes in as 1, 2, 3, or more nodes. Next slide. So that's kind of a mathematically valid way to illustrate that the combined model is better than the recurrence score alone. So it predicts the actual outcome for an individual patient more accurately than just using the recurrence score value alone, or a model that only includes the clinical variables, so the age, the grade, the size. And again, that's well known from the literature that really combining all of this together provides the best model. And this is just a sort of a mathematical illustration of this. Next slide. And this is really the sort of the practically useful part. So this illustrates how this model will actually work. So if you take a patient who is premenopausal, 45 years old, has positive nodes, 1 to 3 positive nodes, and again, remarkably, it doesn't matter if it's 1 or 2 or 3 nodes. So any of these number of positive nodes, and she has a recurrence score of 20, then, and a tumor size of T1, then her risk of recurrence with endocrine therapy alone is 11%, and it goes down to 7% with chemotherapy. So the absolute benefit that she gains is about 4 percentage points. On the other hand, if the same patient characteristics happen, but the size of the tumor is T3, it's a much larger tumor, then obviously the risk with endocrine therapy alone is higher, 16%, and the benefit from chemotherapy is about a 6% absolute improvement. So, of course, you don't need to use these algorithms. This is going to be a website which spits this out for you. But it illustrates the intended use so that you actually get a personalized prediction for risk of recurrence and how much it decreases with chemotherapy. Next slide. So the next few slides are really just examples of this. But what happens if you change the grade from low grade to high grade? So again, it's a hypothetical case, right? 45-year-old woman, 1 to 3 positive nodes, recurrence score 20, grade 1 disease. The risk of recurrence again happened to be 11, and it goes down to 7 with chemotherapy. If she has a grade 3 disease, then the risk is no longer 11%, but 17% with endocrine therapy, and goes down to 11 with chemotherapy. Next slide. And that's for a postmenopausal woman. Remember here, the recurrence score values go beyond 25. And above 25, you start to see the benefits from chemotherapy. So if you just look at the last component with the 3 dots, the dots correspond to an individual patient placed into this kind of nomogram or graph. Again, so 60-year-old postmenopausal T2 tumor, 1 positive lymph node, recurrence score 20. The risk of recurrence with or without chemotherapy is 12%. And we notice that they don't benefit because the low recurrence score. However, if her recurrence score is 35, then her risk with endocrine therapy alone goes from 12 to 23%, and it decreases to 17 with chemotherapy. So that's kind of the intended use. Next slide. So that's the validation result, right? So we went to this CLALIT registry and made predictions for the patients. For every single person, we made a prediction of having a recurrence or not. And then you have a distribution of these predictions, and you also have a distribution of the observed results. So we grouped them based on the predicted distributions into 4 equal categories, like the lowest quartile, the medium quartile, the higher quartile, and the highest quartile. So in these 4 quartiles, there is an average predicted risk. So obviously the first quartile is the lowest average predicted risk, around 5%. And their observed risk was exactly the same, about 5%. And that's what these equal length bars show you, the predicted risk and the observed risk in each of these quartiles. And you can see that these really match each other very well. But if you plot them against one another, then you have a very high correlation coefficient of 0.92. So this really kind of validates that this indeed provides accurate predictions. And this already factors in the treatment that they received. Next slide. I think this is the conclusion slide. You could just go back to the conclusion slide. One more back. Actually, I think this is someone else's slide. Yeah, so this is the last slide. So we build this multivariate prediction that provides individualized risk prediction in endocrine therapy alone and how much it improves with chemotherapy for women with ER positive, HER2 negative, 1 to 3 lymph node positive breast cancer. And the idea is that this risk prediction helps to make a more individualized decision. So it's not on this slide, but I think it summarizes the concept and the value of this pretty well. So when we run these individualized predictions on the RxPONDER premenopausal population, then about 48 or 43% of patients actually get less absolute benefit than the 5% average benefit. And a little over 50% of them actually experiences greater benefit than the 5% average benefit that the trial have shown. And the idea is that this really helps to make a more informed decision, joint decision between patients and physicians, because we also realize that for some people, 1% improvement is enough. For other people, they want to see a 5-6% improvement to consider chemotherapy.
So thank you so much. Responder really is the gift that is going to keep on giving. I think there's so much that we can do and learn from this large trial, and this is so important because it really does help us every day in terms of decision making. If anybody has questions, just pop them in. We probably have time for one, but while we're waiting, there's an ongoing trial called Offset that is also trying to answer some of these questions about the benefits of chemotherapy. And is there any way to incorporate this in prospectively to further validate this or refine it in any way?
So I think we can actually validate this once the data becomes available from that study. But the goal of that study is really to isolate out if the benefit that we see is from the chemotherapy or it is from the ovarian function suppression effect of chemotherapy. So the controversy and the uncertainty about the RxPONDER trial results is it really the cytotoxic chemotherapy effect that benefited these patients despite having really low recurrence scores? Or is it that chemotherapy makes them postmenopausal? So we essentially give them better endocrine therapy, and we know that ovarian function suppression is better than the tamoxifen that most of these patients received. I also want to remind you that this is not necessarily an either-or question. It actually could be both. And it could be that some people really benefit from the cytotoxic effect, others benefit from the endocrine effect. But this is what we will learn from the ENERGY trial that's currently accruing patients. I mean, in the absence of the ENERGY trial, it's a little bit, so it's a little bit uncertain whether it's really safe and equivalent to provide these patients just combined modality endocrine therapy and skip the chemotherapy altogether.
Great. Well, thank you. I think we'll go on to the next presentation. If anybody has any additional questions, I'm sure they can email you directly. So thank you for that, and we look forward to seeing that publication. So the next presentation will be by Dr. Joseph Unger, talking about patient-reported fatigue and risk of treatment-related adverse events in patients receiving systemic therapy in cancer clinical trials. So take it away, Dr. Unger.
Thank you. It's a pleasure to be here. I want to recognize and thank my colleagues and the funding here right up front. Next slide. So these being from my ASCO slides, I necessarily begin at the end and sort of take the take the wind out of the rest of the talk, but in any event, here we are. The key takeaways are that in more than 8,000 patients from 18 different cancer clinical trials, we found that baseline fatigue, that is fatigue that was assessed prior to treatment beginning, was highly predictive of subsequent risk of severe adverse events on treatment, suggesting that in an era of precision medicine, patient-reported fatigue may be an important component of determining toxicity risk, which could aid in treatment decision-making. Next slide. So now starting at the beginning, some background. Fatigue in patients with cancer is common and it negatively impacts quality of life. Patient-reported outcomes assess a patient's direct report of their symptoms and well-being, and research has highlighted their potential to predict cancer outcomes, including survival. Some of that key research has been done by SWOG itself. We examined whether fatigue prior to treatment, which is referred to as baseline fatigue, was associated with adverse events on study. Next slide. So we analyzed 18 phase 2 and 3 cancer treatment trials with baseline fatigue, all conducted by SWOG over a 30-year period. And there were 4 early stage trials and 14 advanced or metastatic trials. We used the CTC-AE, physician reported, to assess toxicity, including grade 1, which is mild, grade 2, moderate, grade 3, severe, which typically requires hospitalization, grade 4, life-threatening, and grade 5, fatal. 13 symptomatic and 14 objective AE categories were examined. Next slide. So fatigue was derived from multiple scales across these different studies. Each measure was mapped to a 5-point Likert scale so that there was a common reference. Binary categories were compared. For instance, we would compare less than some fatigue versus some fatigue or more. We used generalized estimating equations with a binomial distribution and a logit link, adjusting for age, sex, race, and BMI, with clustering by study. Next slide. So here were the findings. Again, there were 8,000 patients who experienced more than 100,000 adverse events across these 18 different cancer clinical trials, which were conducted in 9 different cancers. And here you can see the distribution of the cancers. The plurality were in prostate. There were several in lung, as well as colorectal, a few in colorectal, lymphoma, and breast, and a smattering of others. And patients had a mix of different stages. About 2/3 of patients were from advanced or metastatic trials, and 1/3 were from early stage trials. Next slide. In terms of patient characteristics, we had very good representation of patients who are 65 or older. About half of the patients were 65 or older, likely due to the surfeit of prostate cancer trials, as well as the fact that almost 3/4 of patients were male, again, likely due to the fact that we had a large number of prostate cancer trials. About 10% or 11% were Black, 4% were Hispanic, and 1/3 were obese. And the baseline fatigue distribution here is shown as indicating that about 1/4 of patients had no fatigue at baseline, 1/3 had a little fatigue, another 1/4 had some fatigue, 13% had a lot of fatigue, and 5% had very much fatigue. So fairly good distribution across fatigue levels. Next slide. So this is really the take-home message and the take-home findings. This shows a forest plot of the odds of adverse events risk by fatigue threshold at baseline. So the vertical line at 1.0 indicates the line of equal odds. Anything to the right as you're facing it indicates that those with more fatigue were more likely to have toxicity on study. And what we can see here is that regardless of the fatigue threshold, whether it's at split at a little versus some versus quite a lot, those with more baseline fatigue had about twice the odds of grade 3 or higher adverse events. they had about twice the odds of grade 4 or 5 adverse events, and they had about 3 times the odds of grade 5 or fatal adverse events. Next slide. There was also strong evidence of a dose response pattern. As you can see here, whether comparing a little versus none in the far left, or some versus no fatigue, or quite a lot or very much versus no fatigue, you can see how that pattern is increasing as the level of fatigue, which is compared to none, increases. Indeed, the odds of severe life-threatening or fatal AE increased continuously in a monotonic fashion. And we actually found that for patients with quite a lot or very much fatigue at baseline, the odds of grade 5 or fatal toxicity was more than 5 times greater compared to those with no fatigue at baseline. Next slide. So some of the limitations is that these results could be driven in part by the mix or the case mix of included trials. You saw the 18 trials and how they were distributed, and that could be influential. Therefore, we take these findings as hypothesis generating and suggest that they require confirmation in an independent data source, which would ultimately improve confidence in the results. The results may also not be fully generalizable, especially in their magnitude, which could be greater or less in non-trial patients. Next slide. So in summary, baseline fatigue was highly predictive of subsequent risk of adverse events. It's probably fair to say that these results suggest that fatigue is a marker for underlying disease processes, leading to both fatigue and a greater susceptibility to adverse reactions to cancer therapy. So if you think in terms of your typical causal inference model, you would have something that is causing both fatigue and greater susceptibility to adverse events. If that's the case, then fatigue could be a very strong and highly reliable marker. The findings also suggest that in an era of precision medicine, patient-reported fatigue may actually be an important component of determining toxicity risk and could aid in treatment decision-making. Thank you.
That was great. Thank you so much. I don't know if there are any questions. Oh, here's one. Do you have any ideas about what fatigue might be a marker for?
Well, a marker for some underlying disease process, perhaps the fact that patients who are experiencing, worse symptoms of their disease end up being more fatigued, which also leads them to be more vulnerable to experiencing the adverse consequences of their treatment. I think that's in short what I would. Now, what that is, it could be many things. Could be many manifestations of the disease status.
So we hear a lot about active symptom monitoring in practice, in practices when we're taking care of patients. And, can we combine what we've learned from monitoring patients prospectively in practice to prevent, higher utilization of emergency room visits and other things with the results of a study like this?
I think so. It begs the question, are you thinking of fatigue as something that can be modified to reduce risk, or as something that is a marker, again, as I pointed out? I think in either event, Dawn, it could be meaningful. If you are identifying patients with fatigue and it is a marker, then that suggests that you need to pay added attention to the possibility that these patients are going to be more vulnerable to what's coming in the future with their cancer treatment.
That's fabulous. All right, well, thank you so much. And I think we are going to move on to our last presentation, last but not least, from Jill Hamilton-Reeves, who's going to be discussing the results of S1600, effects of immune-enhancing nutrition on radical cystectomy outcomes. So it's so exciting to see these results being presented, and thank you so much.
Great. Thank you, Dr. Hershman. Can you guys hear me okay? Is the volume okay? Okay, great. So as you can see, Dr. Hershman and Dr. Unger are co-authors on this abstract, as well as many of you that have joined today. Next slide. So just a reminder for those of you that don't work with bladder cancer patients on a regular basis, the radical cystectomy, or the operation to remove the bladder, is a very major surgery. It has some of the highest complication rates that we see, with 2/3 of patients having some sort of complication after this surgery. 1 in 4 have infections, and it's very common in this patient population to witness rapid muscle wasting after surgery. It tends to be a very catabolic surgery, and also keeping in mind that many of these patients have neoadjuvant chemotherapy prior to surgery, which affects their intake of food and staying strong and resilient around the time of surgery. There's been quite a few studies looking at malnutrition and surgical outcomes. Perioperative malnutrition is a major problem in this population, and is associated with higher complications and lower survival. Next slide. Years ago, when I was a young investigator training with SWOG, I brought my pilot study to be considered as something that we could build into a SWOG concept. And this is essentially the conceptual model that we were looking at based on our pilot study findings. So what we find is when someone undergoes a major surgery like a radical cystectomy, there's a skewing of the Th1 to Th2 response, which leads to pro-inflammatory cytokines, almost like a cytokine type of storm. You also see an expansion of these immune cells called myeloid-derived suppressor cells. Those immune cells express arginase, which is an enzyme that, of course, would use up arginine. And so there's a handful of studies that have shown that patients that undergo major operations become conditionally dependent on arginine. So they're deficient of arginine around the time of surgery. And this can be problematic because arginine is needed for much of the healing processes after surgery. It's required for collagen production, nitric oxide. It's important for T cell function, and then, of course, for protein translation, which might be playing into the role of muscle wasting. So in one of our papers from our pilot study, we compared 2 different nutrition drinks. At that time, those nutrition drinks weren't exactly the same, but they were pretty close matched for calories and macronutrients. But the major difference between those 2 drinks was that the intervention drink was fortified with arginine, fish oil, and dietary nucleotides. And in that pilot study, we found that there was expansion of myeloid-derived suppressor cells in the intervention group, but it was less profound. We also found that the patients on the intervention had fewer infections 90 days after surgery and a trend towards postoperative complications. Next slide. The second paper that we published looked more at the inflammatory story, and this is from that same pilot study. Again, in the intervention group, we found that it altered the skewing of the Th1 to Th2 response, reduced pro-inflammatory cytokines, corrected arginine deficiency, and also showed a trend towards preserving muscle wasting. Next slide. And so together, those pilot papers, as well as a group of studies that came out kind of similar, small sizes, became the beginning of our phase 3 trial. So in our phase 3 trial, S1600, we did have a standard base drink. So all of the participants, the base drink was the exact same. With the intervention drink, so the only difference between the intervention and the control is that the intervention drink was fortified with arginine and fish oil and dietary nucleotides. And so the placebo is really an active control in this group. Participants took the drinks 3 times a day for 5 days before surgery, 3 times a day for 5 days after the surgery. And this is the schema. Next slide. So again, this was a randomized double-blind phase 3 trial design, and our primary aim was looking at postoperative complications day 30 after surgery. There was a lot of debate about what to choose for the primary outcome. I'm going to go ahead and kind of put that in here now, because in our pilot study, infection rates was the significant change, and postoperative complications was a trend. However, there were other studies that were showing postoperative complications were different, and the conversations we had with physicians was it was complication rate that would really move the needle and change practice. So that's what we went with. We stratified by neobladder versus ileal conduit. We also stratified by prior neoadjuvant chemotherapy and nutrition status. Next slide. We came up with our population size and did our power calculations using data from a study out of France. And we looked at some secondary outcomes that I will present today, including higher grade complications, 90-day, and 30 or 90 any grade, any high grade events. And then we looked at survival outcomes, progression-free survival and overall survival 2 years after surgery. Next slide. So our participants, we enrolled 203 participants. The goal was 200, so we made that goal. Some noteworthy things in this in our demographics is that there was a high number of unknown. So for people choosing that box for race, there's also a very high number of diversion type of the neobladder. Almost half of the patients had neobladders, which really goes to show kind of the high volume, highly specialized centers that were involved in enrolling in this trial. Another thing that I think is interesting is that moderate malnutrition is a little bit lower than you would expect, but I think it's noteworthy to point out that the DCP asked us to exclude people that had severe malnutrition, and so those patients were not eligible and included in the study. So those percentages are probably artificially a little bit low because those people aren't included. Next slide. And this is what our consort diagram looked like. And at the end, we had 90 patients evaluable in the intervention and 88 in the control. Next slide. And what we found was that there was no difference in postoperative complications at day 30 or in high grade complications or day 90 or day 30 any grade complications. Next slide. We are looking at 2-year survival outcomes, and these data are not fully matured yet. There does seem to be a trend at 2-year overall survival that that is in favor of the intervention group. We have a lot more analyses to do to look into this and let the data come to full maturation. Next slide. So the limitations of our studies are that these survival outcomes are exploratory and not yet mature. They were part of the a priori protocol. We have been focusing on the overall rate of complications, but as I mentioned before, that might dilute some of the more specific effects on infection rates or muscle mass that may be more related to nutrition. And so we have some further analyses to do to hone in on some of those. We also have nutrition biomarker data for the that clearly delineate who took the intervention drinks, those who didn't, even if they're randomized to that. So we will be able to put those data in our primary manuscript as well. Next slide. So the key takeaways is that we didn't find a significant difference at any graded complications by the type of nutritional supplement. Fewer patients in the intervention group progressed or died, but those differences are not statistically significant and require more follow-up. And our future work will evaluate the effects on infection rates, muscle loss, pre-planned 2-year survival outcomes, and actually a lot of other different translational outcomes as well. Next slide. And as everyone has mentioned here, this is absolutely team science. There are so many people to thank, including our patient research advocates, our participants, the funding, my team at University of Kansas, and the incredible people at SWOG. Next slide. And this is my lay summary. And I'll stop here to take any questions on our last minute. It's a little rough to be the caboose.
Yes, I think this is Lee Ellis. I think Dawn had to sign off, which is why I am kind of the backup,
Okay, great.
lurking, behind the curtains here. Any questions from the group? But let me look in the chat box here. Yep, Dawn had to sign off. So you brought back good memories for me because I worked in a nutrition lab. Let's see, should I tell you the years? 1986 to 88. And we always and we did TPN in mice, which is quite different than what you did, but it's pretty hard to get a central line in a mouse.
I
But
bet.
I do want to question, and I think you already answered this question, but with the addition of arginine, which could feed a tumor as well as, feed the immune system of the host, etc. Was there any tendency, any worry whatsoever about the augmented nutrition with specific amino acid like arginine, that there could be changes in oncologic outcomes?
Yeah, that came up when we were going through DCP review, actually. And I think contextually, considering that this is a very short-term intervention, and it's an intervention where we're working in a context where we know arginine is actually going to be depleted. So it's not like we are supplementing kind of super physiological doses in people that have solid arginine status. These are people that we know that their arginine is going to be depleted because of the demands of surgery. And again, it's 10 days, 5 days before and 5 days after. And at least so far, the survival outcomes are looking favorable. So we'll see. Time will tell.
Yeah, it's good to have a good trend. And I
Yeah.
will state that we had that worry about glutamine years ago
Yeah.
as well.
Yeah. Mm-hmm.
So let me see if there are any other questions. There's a thank you from Barbara for recognizing SWOG's patient advocate.
Yeah, we can't do it without you guys. Thank you.
We are at the top of the hour. I will ask, without looking for answers, if people will be presenting at ESMO. If they will be presenting SWOG studies at ESMO, please let us know. And if there's enough good studies that we could do this again, it's nice to know what other people are doing. This was very educational. Any final questions from the group? I'm looking in the chat box. I don't see anything. So we thank everybody for being here today. We thank the presenters. We thank the Hope Foundation for providing so much support at so many different levels. And we will see you soon. Best wishes to all. Have a good day.